Well, hello. Last time we got together, we were talking about potassium and sodium. We started talking about ABGs. We're going to start off today talking about calcium imbalances. If you could find your PowerPoint and go to that slide. Is the mineral from our bones that can be found in our bones and our teeth, and only a small amount in our extracellular fluid. Two types of measurements include 9 to 11 milligrams per deciliter or 4.5 to 5.5 milliequivalents per liter. If you remember, calcium's needed for muscle contraction and nerve impulse conduction. You see the importance of this electrolyte. So we're going to talk about the common imbalances of hypo and hypercalcemia. But before we do that, we're going to talk about where calcium can be found primarily in cereals, fortified, canned salmon, spinach, yogurt, cheese, and milk are some sources, so dairy products. Hypocalcemia, we'll start off there, can be either an acute condition or a chronic condition related to either a disease process that's chronic or poor dietary intake. There is a increased risk for hypocalcemia in postmenopausal women, and there is also a decreased absorption in the intestines in those that have Crohn's disease. So, and it might not be a dietary deficiency in calcium, but possibly vitamin D, which is necessary for the absorption of calcium. If there's an issue with parathyroid hormone, remember that the parathyroid hormone is related to your calcium balance along with calcitonin from the thyroid. So any surgery to either the thyroid or parathyroid can result in a condition of imbalance with the calcium. So there's also a situation with people with kidney failure that because of hyperphosphatemia will have a hypocalcemia. Remember, calcium and phosphate are opposite. When one's high, the other is low. So that's another condition where you see hypocalcemia. Sorry, I went through those slides pretty quick. Hopefully you're following me. Prevention of hypocalcemia would be to increase dietary intake, so calcium-rich foods, those that we just mentioned, possibly taking calcium supplements for those that are 19 to 50 years old, considering 1,000 milligrams daily and a slight increase over the age of 50 to 1,200 milligrams daily. And dietary supplement of vitamin D if sunlight exposure is limited to increase absorption of the calcium. So complications of hypocalcemia include irritability, neuromuscular irritability, up to tetany, which is a continuous contraction. Think tetanus, I always think of lockjaw. Laryngospasm and seizures, respiratory failure, and cardiac failure. So some diagnostic testing done for hypocalcemia includes serum calcium, an ECG, as we'll see in a minute why, as well as checking parathyroid hormone. So signs and symptoms or manifestations of hypocalcemia. The lab values are going to be under 9 milligrams per deciliter, under 4.5 milliequivalents, depending upon which test is done. With an acute hypocalcemia, you can see mental status changes, hyperactive reflexes, diarrhea and abdominal cramping from increased GI motility. Cardiac dysrhythmias, essentially elevated rate as well as irregular rhythm, and can up to and including cardiac arrest. Some other classic signs of hypocalcemia include Trostick sign and Trousseau's. Listed here. So Trousseau's sign, when the blood pressure cuff is inflated around the arm for a few minutes. If there's hypocalcemia, there'll be palmar flexion. You'll see that shift in the hand like that flexion. And Trostick sign is if the face is tapped on the face right by in front of the ear. They'll be twitching on that same side, and that's a positive sign for, both of those are positive signs for hypocalcemia. Interventions for hypocalcemia, of course, is to treat the cause, to replace that calcium. So if it's a dietary issue, teach the importance of proper intake or supplementation, what sources of foods there are, and potentially administer medications as ordered if it's a severe deficiency. It may include IV calcium gluconate or calcium chloride, and that needs to be seriously considered when somebody's having thyroid surgery or parathyroid surgery and that calcium imbalance, and think again why that's so important with any of the excitable tissues needing the calcium. There's the just a review on this slide regarding management of hypocalcemia and the two signs we just talked about. Hypercalcemia can be chronic, which could be an increased intake of calcium, so inappropriate taking of supplementation or dietary. It could be because of increased vitamin D, renal failure, a hyperparathyroidism. If hypoparathyroid is your low calcium and hyperparathyroid is your high calcium. Some cancers and also some increased use of the thiazide diuretic family. Acute hypercalcemia could be cancer of either the bone or blood. Metastases or invasive cancers. Prevention is be careful with patient teaching for those patients taking calcium supplementation to make sure they're taking proper dosing, making sure that they understand the proper range of intake. And complications of hypercalcemia include either kidney stones or bladder stones. Another name for that is urinary calculi. So some signs and symptoms of hypercalcemia would be the calcium elevated greater than 11 milligrams per deciliter or 5.5 milliequivalents per liter. Person may not have any signs or symptoms depending upon how slowly the rate's going up, or can be presented by increased heart rate and blood pressure, and could be skeletal muscle weakness and decreased GI motility. If you think back, we just talked about hypocalcemia presenting with muscle contraction and cramping and hyperreflexes, and hyper would be decreased motility and decreased muscle contraction, so weakness. Some interventions for hypercalcemia, if it's severe, the person will be monitored. Remember, the calcium's affecting those muscles and excitable tissue, and the person will need to be on a monitor. So fluids will be infused. Some medications will be prescribed, such as thiazide diuretics, Lasix, Iridia, calcitonin, to get that calcium down. And if it continues to stay high, an individual may require to get dialysis, either peritoneal or hemodialysis, if needed. This next slide is just one of our review slides that might help with memory of hypercalcemia. And this one just shows a relationship between calcium and phosphorus. It's an inverse relationship, meaning when one's up, the other is down, and vice versa, The last, or second to last, electrolyte imbalance we're going to talk about is magnesium, and its range, normal, is 1.5 to 2.5 milliequivalents per liter. And both calcium, which we just talked about, and magnesium is necessary for our cardiac muscle and nerve cells. So you'll see that often your calcium will be off when your calcium is off. So if we take a look at hypomagnesium, which is normally it's 1.5, hypomagnesium is under 1.5 milliequivalents. And it could be because of a malnutrition or a starvation diet, or excessive loss with somebody that possibly has severe diarrhea or a malabsorption problem like Crohn's disease, and they can't absorb it. Some other causes of hypomagnesemia include alcoholism and your loop or osmotic diuretics, aminoglycoside antibiotics, and at times some chemotherapy. Signs include those for your low calcium, Trousseau's and Chvostek's that we talked about, with the blood pressure and the flexing of the hand, or with Chvostek's, tapping on the cheek causes twitching on that side, and that's positive. Complications include cardiac dysrhythmia and cardiac arrest. So treatment includes treating the cause for the hypomagnesemia and replacement. So magnesium sulfate by IV would be prescribed treatment, and calcium needs to be monitored as well. Here's your hypomagnesemia crew. Take a look at that slide. And last would be your hypermagnesemia, which is when magnesium levels are over 2.5 milliequivalents per liter, and could be as a result of increased intake, or if the kidney's not able to get rid of it. So consider renal failure. So signs and symptoms often will be after the levels rise to over 4 milliequivalents per liter. And the symptoms include hypotension, lethargy, skeletal muscle weakness, dysrhythmia, including bradycardia and potentially cardiac arrest, respiratory failure, cardiac failure, and coma. Pretty significant signs and symptoms of hypermagnesemia. Interventions: reduce the magnesium, IV fluids. Will be prescribed, administer medications such as loop diuretics, and if the kidneys are failing, then dialysis will be necessary. The control of acid and base first comes from buffers that we find in our blood and cells. Proteins, hemoglobin, bicarb, phosphates will either soak up or release extra hydrogen ions. Our lungs A respiratory system will get involved in acid-base control, as we know, by if the blood is acidic, then the respiratory system is going to get rid of some of that carbon dioxide by increasing both rate and depth of breathing to get rid of that CO2, blow it off. And if the blood is alkaline, then the lungs will hold on to CO2 with shallower, slower respirations potentially to increase the pH to be more alkaline. And then one of the other controls is the renal system. The kidneys take a little bit longer than the respiratory system to get involved, but they regulate the amount of bicarb and hydrogen ions that is excreted through the renal system. So if the blood is acidic, the kidneys will reabsorb to the bloodstream bicarb, and if it's alkaline, will excrete more bicarb. And that's the way the kidneys are involved in acid control. So one of the things that needs to be committed to memory is the normal values, because we have to start there as understanding the normal values of the arterial blood gases, and then figuring out what's going on and treating that cause. So you need to, as a nurse, know who's at risk for an acid-base imbalance. So first thing would be your pH of the blood is the normal range is 7.35 to 7.45. And just looking at those numbers, we know our body likes to be a little bit more base in the blood. The PCO2, 35 to 45. And we'll talk about which number is more acid or more base. And bicarb, it says 20 to 26 there, but I'd like for you to add to change that to 22 to 26. And we'll start there. So if we look at the next slide, where we could talk about acidosis, just thinking about the pH, and you have just thinking about the number. The 7.35 and below would be leaning acidic, even though neutral is 7. 7.35 in our blood, 7.34 would be more acidic. So you could have two types of causes, one a respiratory cause or a metabolic cause. So respiratory acidosis or metabolic acidosis. And then alkalosis is greater than 7.5 pH, and again, two causes, respiratory or metabolic. What happens is, as we saw, the control of acid-base balance requires both the systems of respiratory and renal. So when the pH is normal, but the CO2 and bicarb of the ABGs is abnormal, you know that there's been some compensation or some fixing of that abnormality to get that pH back to normal. So let's talk first about respiratory acidosis. There's an increase in carbonic acid, and CO2 is retained. So we'll talk in a little bit about some causes, but that's what's going on, that the CO2 is being retained and therefore elevated. In metabolic acidosis, the pH is still on the acid side, but the reason is different. The bicarb is decreased. You have bicarbonate less than 22 milliequivalents, and the CO2 less than 35. So let's take a look at metabolic alkalosis when there is excessive bicarb. Respiratory alkalosis is when CO2 is decreased or the amount of carbonic acid is decreased. In class, we went over the videos, and you had an assignment going over the acid-base problems. Hope everybody had a good time doing that. The next slide, which is this one now, is just a mnemonic to remember simply acid-base imbalances. So if it's a respiratory issue, the pH is going to be opposite. So if pH is elevated, that means that would be alkalosis. In that case, CO2 is going to be down. And when pH is low, which would be a condition of acidosis, if it's respiratory, the CO2 is going to be high. So the higher the number of CO2, the more acidic. So 35 to 45 is the number we talked about. 45 and up would be your acid. So metabolic numbers are going to be equal. If the pH is up, the bicarb is up, and that's alkalosis. If pH is down, bicarb is going to be down, and that's acidosis. So we're going to start talking about primary, some of the disorders. And you could say that there's a primary or simple disorder when there's one cause only. There's just either a respiratory cause or a metabolic cause. And you could tell if it's compensated because you'll see the pH back to normal. And you see partially compensated and compensated, as we talked about when we last saw. So your kidneys are going to alter the amount of bicarb and hydrogen that's excreted, and the lungs will change the depth and rate of respirations, all to contribute to compensation. There's a video on this slide that you can watch for explaining compensation. Mixed disorders can be tricky because they have both a metabolic and a respiratory imbalance. And I don't think there were any of those on our examples. So this slide shows what is going on with each of the ABG values in the different conditions. So with respiratory acidosis, you have the pH is down, that would be acid, and your CO2 is elevated. So that's your RO part of Rome. Your respiratory alkalosis, if the pH is up, and the CO2 will be down. And then metabolic acidosis, the pH is down, the bicarb is down. Metabolic alkalosis, pH is up, bicarb is up. Now let's talk about each of the different disorders and some of the things that are contributing. So in respiratory acidosis, some causes include hypoventilation and COPD. Drugs, think those that suppress the respiratory system, opiates, for example, or a neurologic problem can potentially be a cause. Signs and symptoms of somebody having respiratory acidosis would be an altered mental status, confusion, lethargy, stupor, all the way progress to a coma. So the treatment for respiratory acidosis includes treating that respiratory problem. Respiratory acidosis, this slide, you have the hypoventilation, which leads to the hypoxia, some shallow respirations, decreased blood pressure, skin can be pale to cyanotic, hyperkalemia, headache, dysrhythmias because of the elevation in the potassium, drowsiness, dizziness, disorientation, muscle weakness. So it could be, like we mentioned, respiratory depression, anesthesia potentially, increased intracranial pressure, airway obstruction, and COPD or pulmonary embolus or anything that's involved with obstruction in the airway. That could be an issue. And as we saw when we did respiratory or COPD, emphysema patients, this could be a problem, or people that have, air trapping and asthma. Okay, respiratory alkalosis is when somebody loses CO2, so it becomes more alkaline, often through hyperventilation, as if an example would be if somebody's anxious or afraid or even in pain. Person that is in respiratory alkalosis will can feel lightheaded or confused, an increased heart rate, and a weak, thready pulse, and the pH will increase. The PaCO2 is going to be decreased. So treatment can include slowing down that breathing, using pursed lips, pursed lip breathing, and that we talked about, like that brown bag use. Talking about respiratory alkalosis, hyperventilation would be the cause, increased rate and depth, tachycardia, decreased or normal blood pressure. Hypokalemia, whereas remember you saw hyperkalemia in the respiratory acidosis. Numbness and tingling of extremities, hyperreflexia or cramping, seizures, increased anxiety or irritability. So hyperventilation, and it can also include mechanical ventilation, being on a ventilator can contribute. Metabolic alkalosis is when there is too much acid or too little bicarbonate. And some causes include uncontrolled diabetes, think diabetic ketoacidosis, end-stage renal failure, severe diarrhea, or prolonged intestinal suctioning, which can increase the loss of the bicarb. So signs and symptoms include increased serum potassium with metabolic acidosis, because those hydrogen ions go into the cells in exchange for the potassium, which will leave the cell and go into the blood. So you'll have Kushmal's breathing, that rapid deep breathing to blow off carbon dioxide. Number one, treating that underlying condition. So if it's diabetes, that needs to get brought down. So this slide just is a pictorial view of metabolic acidosis. And again, too much acid or too little bicarb. So it could be because of DKA, could be decreased elimination from renal failure. So it's a serious complication of either renal failure or diabetes most often. So metabolic alkalosis can come from increased ingestion of bicarb. If somebody is taking a lot of antacid, Tums or Rolaids or such, or increased loss of acids from the body. So if somebody's prolonged vomiting, intractable vomiting, or suctioning from the stomach, loss of acid occurs. So in metabolic acidosis, it's intestinal suctioning, and that's where a lot of bicarb can be found, whereas a lot of acid is found in the stomach. So suctioning the stomach, you're changing the acid-base balance. So decrease potassium in the blood, because hydrogen ions move from the cellular fluid to the intracellular fluid to the blood, and then exchange with calcium moving into the cells. So you may also see hypocalcemia. Signs and symptoms look a lot like hypocalcemia or hypokalemia. You need to treat the underlying cause. So your metabolic alkalosis Symptoms can be confusion, irritability, nausea, vomiting, diarrhea. And some of the signs of hypocalcemia and contributing factors, somebody's taking too much antacids or too much suctioning. So that's just a pictorial view. The last few are some questions that you can see in your book. And we're going to get started.